Good morning, my name is Sorcha McPhillips. I'm the Chief Executive of the Huntington's Disease Association Northern Ireland. This morning we're joined by Elaine Stiles. She's a specialist speech and language therapist, and she's based over in the West Midlands with their Huntington's Disease Regional Service. Elaine's going to give you a presentation this morning looking at aspects of communication and swallow with Huntington's disease, and in that she'll be addressing some of the questions that have been put forward to her before this morning's session. Okay, Elaine, whenever you're ready, you can get started.
Good morning, everyone. Hi, I'm Elaine. Thank you very much for inviting me. It's nice to have the opportunity to talk to you this morning. So yes, I'm going to be talking to you about communication and swallowing in Huntington's disease. So I'll just carry on with my first slide. So what I was hoping to cover this morning is these following things. You'll probably be aware of the three areas that we talk about in relation to change or difficulty in terms of Huntington's disease. So we really think about the area of cognition, of psychiatric changes, and of motor changes as well. So we're going to be having a look at those. We're going to be thinking about the communication changes that we see in Huntington's at different stages and the speech and language therapy role along those changes. Going to be having a little look at some strategies to support communication. We'll also have a little look at what we think about when we think of eating and drinking needs, and the impact of those key areas, motor, cognitive, psychiatric changes on eating and drinking as well. And then a little bit of support, ideas of support that speech and language therapy can offer with eating and drinking needs too. In terms of the role of speech and language therapy in Huntington's disease, we've really got two roles. So we have the supporting with the eating and the drinking and the swallowing, and obviously support with communication as well. And both of those are really key in Huntington's. So in terms of eating and drinking, a lot of my role is working within the, as part of the MDT, to try and provide a really holistic, client-centred and management, and I'm really lucky where I work because I work as part of a really supportive MDT, which is brilliant. Management usually includes the production of some recommendations for safer eating and drinking and swallowing, and really the overall aim is to think about reducing risks of chest infection, of choking, of people becoming dehydrated or malnourished. There's a big role as well in terms of future planning, so trying to consider and understand people's wishes for eating and drinking in the future, and we try to introduce this early to give people time to consider what is right for them. In terms of communication, we would be looking at speech. So as you might be aware, we often see a speech difficulty, dysarthria, in Huntington's, which I'm going to be talking a little bit more about. We also like to look at people's understanding of language and their expressive use of language, how they use that. But I think probably most importantly is kind of the social environment around communication. I like to look at people's strengths and needs and how they use communication, and are they able to meet their needs with their communication, and within that we might look at the skills of people's communication partners as well, so their family and their carers. We might consider, do they understand the needs of the person with Huntington's? Are they able to recognise, for example, when the person with Huntington's has perhaps not understood what's being said to them? And obviously we're looking at trying to maximise intelligibility through work with individuals and their families and carers themselves. A big part of our role as well, I think, is trying to support participation, because if you've got a difficulty with communication, it can be harder to access those social opportunities. And then we also have a role around mental capacity assessments as well, so supporting people to understand relevant information and communicating important decisions. So hopefully that's a little bit more on what exactly you could expect from a speech and language therapist. So initially we're going to look at communication, and we're going to look at each of these areas in turn. So motor, cognitive, psychiatric, and I'm going to try and describe how changes can impact upon communication within these areas. Okay, so when we're speaking, we need to use a lot of different muscles, and the chorea that we see in Huntington's affects the production of speech at all levels. So what we see is often, not in all cases, a dysarthria. And we can see that that affects respiration, phonatory levels, resonatory levels, articulatory levels, and prosody too. So in terms of speech, when you think about speaking, you need breath support for speech at first. So it starts in the capacity that you have in your lungs, and then the breath needs to come up. It needs to go through your voice box so that we can get voice. It needs to come through your throat and your mouth so it can resonate and we can make sounds. And then we need to move our articulators, so our tongue, our lips, our mouths to make different sounds. So all of that gets can become affected in Huntington's, and I'm aware in terms of respiratory, we might suddenly see perhaps a forced inspiration of breath or expiration. That might be something we see. In terms of the level of the voice, so phonatory level, we might see some vocal strain, or we might see harsh sounding voice. And we also might see excessive variations in loudness, which I know was a question which was given prior to the session. It is possible to see variations in voice, and it's to do with difficulties controlling that, and there's not always awareness of that. I would suggest to you perhaps that you contact your local speech and language therapy team and ask them for support with that. There can be some awareness raising that we can do for people, perhaps with using some kind of visual support, perhaps some kind of rating scales that could be helpful. So I would advise you to do that. Also, we can have some effects on prosody as well. So the natural kind of sing-songy intonation patterns can become affected too. So that's something that we see. And also, I suppose separately from speech itself, you have to think about communication as being a bigger thing, really. So obviously we use non-verbal communication, we use our hands, we use gesture, we use facial expression, and those sorts of things might be more difficult as well for people with Huntington's. Not always, but sometimes we find it might be harder for them to communicate emotions using their faces, for example. Right, so cognitive changes also impact upon communication. So we can see some short-term memory issues which will impact upon how people communicate. We need to be able to maintain attention to our communication partners to successfully exchange information with them. We also need to be able to plan what we want to say and organise our thoughts into an order that people can understand. So if you've got difficulties in those areas, then that's obviously going to impact upon your communication. Also, specifically for language, we might see some difficulties understanding more complex discourse. We may see some word finding difficulties. We may see some perseveration, which you may be aware of, people being perhaps stuck on a specific word or phrase or idea. So we see that fairly regularly. And then in terms of pragmatic language skills as well, that's looking really at social skills around conversations. So the unwritten rules we adhere to when having a conversation. So things like taking turns in conversation, sticking to topic, and those things can become affected too. So we may see people not initiating communication as much, that's sometimes reported. And we also may see a slowing down of processing of language as well. So people taking longer to respond during conversations, taking longer to process and understand what's being said. And obviously that can impact then upon turn-taking skills, because if people are taking longer to process what's being said, it's somebody else might butt in, think that they've not heard, ask them again, and it affects turn-taking. So there's lots of things going on at a cognitive level as well. In terms of psychiatric effects, I think we can really easily understand how feeling anxious or depressed or experiencing apathy can affect our motivation to communicate. And we can see how not being involved in communication with others could put us at risk of social isolation. So it's something that we need to be aware of and proactively addressing. People do report feeling irritable, and family members often report observing this in their family members or carers too. And sometimes this can impact upon new learning. So if we perhaps have ideas for communication strategies or new things that we would like to introduce, sometimes we have to kind of work around the fact that that person perhaps might be feeling a little bit irritable about something, perhaps finding new things more difficult to take on, perhaps. And then we're also aware that personality changes can be seen. And this alters conversation that we see between people who know each other well. So it changes the dynamic a little bit as well. And I suppose if you think, for some people, not everyone, if as a result of HD you've had a change to your daily routine or the daily activities that you do, then sometimes you haven't got perhaps as many things to talk about, or you may have different things to talk about. So that all impacts upon how successfully people interact with each other. So basically, speech and language therapists are interested in maximising communication skills by working with individuals themselves, of course, and with their communication partners too, so their family and their carers. So I'm going to talk to you about what we may see in terms of communication changes at different stages of Huntington's, and how we can support at these stages. Obviously, this is just speaking really generally because people are individuals and may not go through these stages, but this is to give you a general overview. So firstly, in the early stages, the first sorts of changes which we could see might just be picked up on the individual themselves, or perhaps known communication partners. So may not be obvious to people who don't know the individual so well. So we might see some mild or fluctuating speech difficulties, so some slight slurring of speech, but it doesn't generally have much of an effect on how easily that person is understood. We might see some difficulties understanding more complex language. And we might see some differences in how likely that person is to initiate communication. In terms of the SLT role at this stage, I try to offer support by explaining some of the changes that might be experienced and some of the strategies that could be trialled to make things easier for people. It might be that somebody may benefit from some Dysphagia therapy, so perhaps some direct speech work could be possible with an emphasis on breathing or relaxation techniques. Sometimes raising people's awareness themselves of their own speech and things that they can do to enhance their intelligibility can be helpful. So prompting people to slow down, leave gaps in between words, that sorts of thing. And then we might also be involved in making suggestions for adaptations that people can make to support their functioning in everyday life, really. So perhaps using calendars, notebooks to help remember key information. So that's really early stage. Towards the mid stage, some people might start to experience more mild to moderate type of speech difficulties. So speech now might be becoming a little bit more difficult for people to understand. And because of cognitive changes, you may see people experiencing more difficulties in applying strategies that might have been taught before, not always, but it could happen. And sometimes when people have awareness of these difficulties, they may be tempted to start avoiding social situations. So often people will say to me, I don't really like talking in groups, or I don't really like talking when it's very noisy restaurant environments, that type of thing. So people are beginning to appreciate the social impact. So in terms of what we might do, producing clear speech might be more difficult, as I said. So the speech work might now perhaps focus on ensuring key needs are met through speech. So we may be practicing functional phrases that are important for people. We might be trying to introduce systems to support communication, such as communication books, photograph books, alphabet charts, and these can help to maintain social relationships and opportunities as well. So something like a life storybook with photographs might be really helpful in sharing with somebody else and enabling two people to have a successful conversation together. And at this time as well, we're usually trying to encourage discussion about future care plans, and often we can do this is supported by using talking mats sometimes. I have a little image of talking mats there. I find it really useful. People can use that to visually think about how they feel about things in their life, to think about how they might want to change certain aspects of their life. You know, we take photos of these mats once people have used them. We can record discussions by taking photographs of these mats. So it's a really useful way to support people to communicate. By the late stage, sometimes we're finding that slurred speech may be making it more difficult for people to communicate. Sometimes we find that people's motor difficulties impact upon their ability to use more complex communication systems. So things that would need, hands to operate a very high-tech communication aid, for example, are usually not something that we would pursue. I mean, not in all cases, but generally what we're finding is that the more low-tech communication visual supports are more successful, really. So more picture-based, symbol-based communication systems. So what we're trying to do really towards the later stages is focus the intervention with family and carers, and enabling them to support the person with Huntington's and really sort of take a bit more responsibility, if you like, for the success of the communication interaction. As I said, we would probably be looking at using more low-tech communication systems, and we find then that if people have already experienced those earlier on, then those are more likely to be carried on and stuck to during later stages. in the later stages, for many people, it's vitally important to establish a consistent yes-no system, so people are able to meet their needs, so they can communicate hunger, thirst, discomfort or pain. Those things can be really, really important. For some people, we might think about producing a communication passport. So this would be a document which describes someone's perhaps non-verbal behaviours and their meaning. It might include some specific advice on how to support that person during eating and drinking, for example. And people often tell me that these documents are useful for perhaps the person with Huntington's might be going somewhere where people perhaps don't know their communication so well. So perhaps they're having a respite stay, or perhaps they've got new carers. So it can be a useful way of making sure that really important information about how someone communicates or needs support with eating and drinking is shared. In terms of strategies to support communication, these are really a lot of the general advice that I give to a lot of people. I know there was a question that came up before about how somebody could support a family member with slurred speech. So I would say some of this advice here may well be helpful to you, but I would also request a communication assessment from your local speech and language therapy team, because it might be that some kind of visual tool is an option. So some kind of picture-based, symbol-based communication system. Those tools can be really helpful in reducing frustration for a lot of people. So I would definitely recommend that you do that. So we would always think about the place that you're having conversations and the time that you're going to have them, you know, allowing lots of time and thought for people to, express their ideas to you is really important. Listener giving the speaker their full time, you know, not be doing something else while you're listening. Reducing distractions and background noise can be really helpful. It enables the speaker to concentrate on the communication task. So then there's some things to consider perhaps before you, before you start talking. So, you know, perhaps identifying the topic that you're going to talk about. Sometimes that helps people to stay focused. Always, I would say, using some tools to aid conversation. So just something visual, something that you can use to support what you're saying with speech. Making use of natural communication gesture, facial expressions would also help make the conversation successful. There's some advice we give about keeping conversation going. So things such as how to rephrase messages, so saying something in a different way, using a different word or different phrase, perhaps simplifying a message, so using just a keyword or providing a visual clue can be helpful. Sometimes using just a yes/no question is better. I know we like to give people choice, but sometimes that can be a little bit overwhelming for people, and it can be helpful to reduce people's options. So perhaps instead of saying, what would you like to drink? Sometimes directly saying, would you like a hot drink? Might be less overwhelming for some people. And supporting perseveration as well could be helpful. So as I said before, sometimes people might get stuck on a specific idea or, you know, and find that difficult to move on. And when perhaps others feel that they've changed the topic now, there might be some, you may see the person with HD wanting to come back to that same topic. So in that case, we find it's quite helpful sometimes to kind of give a little bit of a marker in terms of saying, we've finished talking about that, now we're going on to talk about that. Sometimes just signalling that to people can help. Also checking understanding and encouraging a slowing down of the rate of speech can be helpful too. Leaving clear spaces in between words, things like that. So I've moved on a little bit ahead of myself now into swallowing, which is obviously another key part of my role. I've lost my, oops, marker for moving. There it is. So why do we eat? Obviously, it's about sustaining nutrition and hydration, but it's also so much more than that. So if you think back to the last social occasion that you were part of, the chances are it involved eating and drinking. So generally all celebrations that we're involved with involve food and drink. So it's a really, really important thing. And when it changes, it has big implications for people. So I'm just going to quickly whiz you through a normal swallow. It's a really rapid, complex process. So at the start, we have the oral preparation stage. So that's before anything enters your mouth. So this is being in the environment where food is being prepared, smelling food being prepared, hearing sounds of food being prepared, and the sight of it. So we're looking at it, we're deciding, how does it look? Does it look appetizing? Does it smell appetizing? And all of those things are getting us ready to eat. When obviously we move into the oral stage, when we first put something in our mouth, and we've got quite a lot of complex things going on there, and we have to make sure our lips close, we have to make sure we can chew the food, our tongue has to move the food around to the right place in our mouth. Our tongue has to transfer the food to the back of the mouth so that we can initiate the swallow. And then once we swallowed, we move into as we swallow, we move into the pharyngeal stage, which is very complex movement of muscles to allow for the food and drink to be directed towards our food tube, so our esophagus, and away from our airway or away from our lungs. So it's a really complex movement of muscles, and it's very slick. So when it works normally, it's efficient. By the esophageal stage, that's when the food is moving down towards the stomach to the right place. So that's your normal swallow. So it relies on a really rapid coordinated movement of muscles to protect the airway and successfully direct food and drink towards the right way, as I've just said. So in Huntington's, what we sometimes can start to see is that this system is affected by changes in coordination and strength of those muscles involved. So they're the same muscles that are involved in speech. So as you see changes in speech, then you also may see that your swallowing function isn't quite as slick as it was before. So this is a definition then of dysphagia, and I'll perhaps give you a little minute to read that through. I really like this definition because it's very holistic. So it reminds me that eating and drinking isn't just about your head and your neck area. There are physical, cognitive, emotional factors that all come into play, and they all need to be considered. So I suppose, why do we need to think about managing swallowing difficulties? And often people will say, perhaps carers will say, oh, that, you know, they cough, they've always coughed, it's part of what they do. And I suppose I would then say, okay, but we need to get this checked. We need to make sure that this isn't going to cause anybody any difficulties. It might be that an assessment and some recommendation for different sorts of foods or drinks would make somebody safer and would reduce that coughing. So what we're ultimately concerned about is chest infections. So if we have food and drink which is going down the wrong way, which the muscles don't quite manage to send the right way and head towards the airway, towards the lungs, if they hang around in there, then they can cause chest infections, they can cause people problems. Obviously, we have a choking risk. So if something gets stuck, obstructs the airway, we can have choking incidences, which is obviously really worrying, dangerous. We need to try and avoid those. Obviously, there's risks of dehydration, malnutrition if food and drink isn't getting to the right place. And there's, you know, there's issues around individuals and carers being anxious about food, being aware of the fact that their swallow has changed and they find that difficult when they're going out, so perhaps they're choosing not to go out anymore. So there's a big social aspect that we need to try and address as well. So it's very complex. So in terms of areas of difficulty that we may see in relation to dysphagia, really the same key areas, motor, cognitive, psychiatric, all have impacts upon eating and drinking as well. So I'm just going to try and quickly whiz you through what we might see as well. So in terms of motor, we're thinking about movements. So we can think about the general body. So in terms of being able to eat and drink successfully, obviously you need to be able to sit still, you need to be able to maintain an upright head position, you need to be able to use your arms, hands to raise food and drink to your mouth, and sometimes that can be difficult for people with HD. In terms of muscles specifically related to eating and drinking, then as I was previously saying, we can have a reduction in the strength and the range of muscle movements of our lips, our tongue, our jaw, and that's going to impact upon how we can successfully move food and drink around in our mouth, move it backwards to where it needs to be. And then we can have a reduction in our ability to control the direction of food and drink, which is what I was saying about it going down the wrong way. So if it goes down the wrong way, we might see aspiration, we might see choking. And there was a question that I wanted to address about this as well. Somebody who was concerned that a family member was avoiding water because they were finding that was making them cough. So what we find with water is that it's a very thin liquid, it moves very quickly. So if you're having difficulties with your muscle control with your swallow, then you are likely to have difficulties managing water because it's thin, it'll move quickly and it can quickly go down the wrong way. So that might be why thicker, I think you mentioned milk being a little bit more easily tolerated. That might be why, because it's a little bit thicker. But I would definitely be advising you to access speech and language therapy. You would need a dysphagia assessment to have a look at that. We can thicken up liquids, we can make them a little bit thicker, which sometimes makes them more easy to control, easier to direct into where we want them to be. But you would need that to be assessed by a speech and language therapist and advised, really. So I would definitely say to do that. So in terms of changes and how that impacts upon eating and drinking, so if we see people whose mood is affected, then that can impact upon appetites and interest in preparing food. We might see people who are scared of perhaps choking or scared of spilling food onto themselves, making a mess. People worry a lot about how they perceive themselves to be a messy eater. There was also a question about what I would advise in terms of supporting somebody who had a fear around eating and drinking. I think if somebody's had a choking experience, it can be very, very frightening to eat again, and very, very frightening for the people that are supporting that individual. I would hope that if there has been perhaps a choking incident, then you would have accessed or been able to access a dysphagia assessment, and that you would now have some safer eating and drinking recommendations as a result of that. You might have been advised to have a different diet consistency. So hopefully those things are in place. But I would say remaining calm, trying to keep meal times as natural as possible, because obviously if we're picking up on stress, then that's not helpful. So trying to be as natural as possible, encouraging slow, careful eating, and I suppose offering reassurance that you know, if that person has had an assessment and they've been recommended a certain consistency, then that has been advised for them, and that is recommended in order to reduce risk. So hopefully that will be reassuring.
That's great, Elaine. Thank you very much. I'm afraid we've run over time. I know that you have a few more points in the presentation, and there's some questions that need to be addressed afterwards. But we're running into the next session now. So if you want to just wrap up with a few key points, that would be great.
Yeah, okay. So apologies, that time runs very quickly, doesn't it? Let me just see. What do we assess? We could probably say what support we can offer. There was another question around what the sorts of things we advise. I know that equipment was in that, so I'll leave this slide up because you'll be able to see the sorts of things that we recommend. In terms of equipment, it's really individual based, you know, on specific individuals, but generally speaking, non-slip mats, very helpful. Keep warm plates, so things that would keep food warm if food is taking a little bit longer to eat are really helpful. Wider handled cutlery, perhaps polycarbonate cutlery as opposed to metal, just in terms of it getting perhaps accidentally bitten or causing damage to the mouth. Lidded cups, because sometimes the involuntary hand movements mean that liquid is spilt. Sometimes lipped plates that have like an edge over mean that people are more likely to be able to feed themselves and not lose food over the edge. So those are the sorts of things that I would recommend. Gosh, what else to say a little bit about that? I'll leave that up for a little while.
That's great, because everybody's going to get your presentation, and then we'll be able to address some of those questions in their follow-up email as well.
Yeah, okay. I'm aware that there was a question about future care planning, which I really wanted to address. So I'm sorry I've run out of time for that, but I would just ask that person to have a think about advanced care planning and to have a think about advanced decision to refuse treatment. Those really are, if you have expressed your wishes in an ADRT, then I think in Northern Ireland they're perhaps not legally binding as they are in England, but health and social care teams should respect your decision where possible. So I really ask you to look into that. But yes, of course, follow anything else up, any other questions, I'm happy to follow up. Sorry, I ran over.
No, you're grand, you're grand. Thank you so much for your time, Elaine. And as I said, we'll follow up with all participants. They'll get a copy of the PowerPoint and the video, and as well as that, there'll be some additional questions and answers provided to you as well. So thank you all very much for your time.